You probably know that Kevin is also from Maine, but he works in Phoenix, and I was jealous of him because up in Maine we're not blessed with many of the toxic species that others deal with. Kevin was saying every morning he gets up and he dusts the highly toxic scorpion from his clothing, and then as he walks out to the car every morning he sweeps away all the highly dangerous snakes on his way to work. We don't have those kind of things in Maine. Instead, we have mushrooms, and just a small plug, we will be having a medical mushroom meeting. We're still kind of fooling with the title. Shoreside Shroom Symposium didn't seem to work very well, and fungi and other toxic pickups didn't. These were all rejected as titles for the meeting. Unfortunately, it's the weekend right before NECCT, so it's going to be trouble for most of you. This is also a paper from a French group. This is a group of hepatologists, gastroenterologists, and transplant surgeons in two places, one in Clichy, which is a suburb of Paris, and then Toulouse to the south. And this was a retrospective review of 27 patients over an 8-year period. Their inclusion criteria were folks who were admitted to the referral hospital for Amanita Phalloides poisoning. So this article presumes a bit of background knowledge, and I won't spend a lot of time on this, but and Mike covered some of this, but besides Amanita Phalloides, which is responsible and most serious for anywhere from 85 to 95% of the fatal poisonings, there are a few other Amanita species that do contain significant amounts of amatoxin, and those are listed here. All of these, by the way, do grow in Maine, with the exception of the Galerina venenata, which is a Pacific Northwest mushroom. The first group is collectively known as the destroying angels, and the Canosabe is one of the dunce cap or cone heads. Those are little fragile mushrooms that you can sometimes see on some of the manicured lawns. Otherwise, these tend to grow in the forest themselves. And there was a case report of a Lepiota in New York State, which caused a death by liver failure. The common features, macroscopic features, are a symmetrical cap and stem. These all produce white spores, although the gills themselves may not always be obviously white. These are free gills, and they tend to be parallel. They come all right up to the stem, but don't touch the stem. And they tend to have this very bulbous base, which again, if it's broken off by a child or someone picking up the mushroom, that may not be evident. But again, the trouble is that not all Amanita contain amatoxin, and there are non-Amanita that have amatoxin. And I won't cover this exhaustive list that you can find in a number of textbooks. There are a couple of toxic herbs. This is actually American germander, but most of the literature, again, is from France, European version. It's a weight loss drug that was taken, and it's highly hepatotoxic. There have been some FDA warnings about that. This is pennyroyal. Apparently Pliny the Elder had mentioned this in his original treatise. The pennyroyal has the pugone, and that comes from the Latin pulex, which means flea. This was burned for its anti-insect properties. And then finally, the comfrey is an example of some of these pyrrolizolidine alkaloids. I just want to mention that link there. Sloan Kettering has a very nice compilation of medical herbs. So what is acute liver failure? Some subdivisions, hyperacute, acute, and subacute. Basically, it occurs in less than half a year. It excludes those with preceding chronic liver disease. And you see some of the definitions there. And the definitions include that this progresses on to multi-system organ failure, including the most important organ, your brain. There are a variety of mechanisms. Again, I think we'll skip over these, but that's just for completeness. In terms of the amatoxin itself, and Mike mentioned this, the specific transport protein is the OAT-P, the 1B3 protein. And as he mentioned, silymarin is a competitive antagonist of that transport protein. And interestingly enough, there's a group that published a paper in Germany that rifampin is also highly active at that particular transport protein. So what this paper was about was looking actually at the prediction for the need of liver transplant. Remember that prior to liver transplant, those people with acute liver failure had a mortality of anywhere 60 to 70%, after which it was more on the order of 10 to 20%, which mirrors what the mortality for severe mushroom poisoning is. The X's actually represent all the things in this paper which were not found to be helpful, and I'll get to that at the end, but this is the complete King's College criteria, including both the acetaminophen and non-acetaminophen criteria. Now, the Clichy criteria were actually the criteria in place during this 8-year period when these 27 cases were collected, and I believe that this and the encephalopathy was not helpful. I believe this particular article was actually written in response to Dr. Ganser, who I believe is in Germany, in Munich, writing his own criteria in response to other scoring systems. And he used these two criteria, although he actually responded to this article in a letter and he said, no, I said that it was prothrombin index or creatinine. Not what this article quoted as that both were necessary. And again, creatinine was not helpful. We'll talk a little bit about that. There are so many scoring systems out there that it's hard to keep track. And there's actually, I don't know if anybody's from Johns Hopkins here. There's also a one that I even saw in the past week, a Klein score, a surgeon there. So their methods were, there was a retrospective review, these 27 patients were included, their outcomes were survival and transplantation, but they had obviously very small numbers, and this was a referral hospital. Their results, it was interesting that if you, I felt bad for the two people who were transplanted and survived, because they were actually included in the fatal intoxication group, but this was their mortality rate, which was 22%, or if you included the two people who were transplanted and died, it was 30%, so slightly worse than our more recent data in our data in the United States. Risk factors, and what I learned from this article is that if you suffer from severe amatoxin poisoning and you're female, please leave France, go somewhere else, because the males did much better than the females in this group. There were other markers associated with a more severe case, including higher lactates and more coagulopathy. What they found were when they retrospectively applied these scoring systems, it took 48 hours to fulfill the criteria for acetaminophen related King's College criteria. But these other scores didn't do quite as well as those, and the King's College criteria had many factors included that were irrelevant or were not useful in the consideration for whether a transplant was needed. So in conclusion, when they reviewed these papers, they found that there is a short interval from the onset of ingestion to diarrhea, and they thought that this might be a critical early marker, and if we have an influence over the process to push people toward transplantation. They found that this process is so rapid that oftentimes people don't progress to multisystem organ failure, including they oftentimes don't develop encephalopathy. They may not develop renal insufficiency, and that the best marker was a prothrombin index of less than 10%. They mentioned this just once at the very end of the paper, that because this is a single organ failure, you may consider these patients for auxiliary or partial transplantation, because there is at least one case they mentioned where the liver regenerated despite all the markers suggesting this person go on to die. And that's it. Thanks.